So to get started, I'm Kavita Nyanasamandan. I'm the co-founder and chief commercial officer of Blooming Health. I will be moderating today's panel discussion. I want to start by introducing who we are and how Blooming Health is involved in community-based partnerships. So at Blooming Health, we are a technology company, but we work very closely with community-based organizations to help them to connect with their clients where they are via text, voice calls, emails, and in 80 different languages. Our goal is to break the technology and language barriers that limit access to community-based support services for underserved populations. And we did this as a first social health solution, not only integrating engagement, but also that of social needs screening and closed loop referrals and outcome surveys to track specifically how social services is impacting the health outcomes of individuals and integrating the data back into related stakeholders and other important systems to see the whole person's picture from the needs all the way up to outcomes. So our goal is to help be that small tool in the toolbox to help integrate social care with healthcare, especially empowering the community-based organizations to build capacity and use technology in a way that can help them meet older adults and underserved community members where they are. So we started in New York in 2020, but now we are working with 670 community partners across 16 US states and are really excited to work with all these community partners. Especially, we are students of the space. So as we learn about new things in the space, we want to share the knowledge with the extended community partners in our network and that of the others. So that's why we're organizing these webinar series. This is the second session we are doing in a month or so. And in the next month, in June 21st, we are also doing an in-person one whole day conference called Blooming Day. It's happening in New York City. Everybody's welcome. And we have a whole day of sessions and panels with very interesting speakers, all the way from Chelsea Clinton to Greg Olson, the New York State Office for Aging Director, Claire Casey, the CEO of AARP Foundation, Bob Blancato, and also many others, as you can see on the panel itself. So we're going to be posting the link for this conference in the chat. So feel free to check it out and register and attend it. You can do it both in person and virtually as well. So now to get into the session itself, as I said, today the topic for the session is community care hubs, learning lessons and successes. And we have three esteemed speakers with us. June Simmons, who's been the CEO of Partners in Care Foundation. She is joining us, and we were just talking about this earlier. They've been one of the first organizations in terms of leading the development of community care hubs and networks in the country, and they're based out of California. Partners leverages a large-scale CBO network to improve health outcomes for one of California's largest health plans. Their Partners at Home network has achieved significant results, including a 50% improvement in medication adherence and a 24% reduction in 30-day readmissions. June Simmons is also the co-chair of Partnership to Align Social Care, a national learning and action network for designing successful social and healthcare partnerships. Really grateful June could take the time in her busy schedule to join us today. And then we also have Kelly Cronin joining us from Administration for Community Living. She's the Deputy Administrator for Innovation and Partnerships. She leads the administration of programs and initiatives that serve both older adults and people with disabilities, including consumer access and protection programs. She also directs efforts to develop and integrate networks of state and community-based organizations to address social determinants of health. And lastly, we'll have Paula Johnson joining us from Harris County Area Agency on Aging. She'll be joining us in a little bit after 10 minutes or so, but she is the Bureau Chief in Harris County Area Agency for Aging, and she's been serving there since 2017. The Area Agency for Aging in Harris County is actually embedded within the Houston Health Department. Prior to her role in the AAA, Paula served as the Senior Contract Administrator and Human Services Program Manager for the Care Transitions Program, Information and Referral and Assistance, and Benefits Counselors within the agency. She is most proud of her 27 years of service in the United States Army. And today, Paula is also joining us to share her experience in developing the Community Care Hub and network for Harris County over the last year or so. So really excited to have this discussion and get this going. To begin with, I want to start with a question for Kelly to start us off by helping us understand the community care hub model and how it all got started, especially in terms of the different funding and innovation that has gone into shaping the network over the last few years.
Yeah, thank you for inviting me, and nice to be with everybody today to talk about community care hubs. So in response to your question, I think the term community care hub is perhaps a newer one that not everyone is familiar with, but the concept and the actual work of what hubs have been doing have been around for a long time, decades. But I would say really in the last 10 years, we've seen within the aging and disability networks, a lot of maturation of community care hubs. Again, maybe these community-based organizations such as area agencies on aging or aging and disability resource centers or centers for independent living that are playing the role of a hub have not always self-identified maybe as a community care hub, but they have been active partners with healthcare providers, whether it's a local health system, community health center, or Medicaid managed care organization, Medicare Advantage organization. There's a lot of different types of healthcare partners they have learned to collaborate with and have contractual relationships with the intent of providing more sort of holistic services and support. So if somebody has food insecurity or housing needs or they need access to transportation, or they're socially isolated, they need home modifications, they need more supports at home. There's really a spectrum of needs that they identify and support, but are able to do that collaboratively with healthcare partners, and be that sort of trusted entity that has a better reach usually into the home and is be almost like the eyes and ears in the home, if you will, can be an extender to the care team. And again, being that sort of trusted partner where they, in many cases, have been in the community for decades and are known to a lot of people in the community, also able to provide, culturally competent and sensitive support, to really maintain that trust and really be effective in relating to people and understand what's important to them and their preferences and their desires. So the hub model, again, having been around a while, I would say some of the precursors or sort of maybe catalysts to support this has been the community care transitions program that June's organization was part of, and many others across the country. It was part of the Affordable Care Act implementation, where community-based organizations partnered with hospitals to be able to support safe transitions from hospital to home. And we're able to do that in many cases with a lot of success. And June can elaborate on everything that's happened from her perspective, what she's seen in Southern California. But I think we've seen that be an incubator for, lasting partnerships with health systems and knowing how to embed and work within their workflow, but then really follow the person all the way home to be able to make sure that they have the right medications, the right supports, the fall risks are identified and addressed and, sort of really fully supported. So there's that as one catalyst. I think we've also seen the Centers for Disease Control and Prevention support this model through their diabetes prevention program. They have supported umbrella hubs to be able to have these relationships, to be able to provide diabetes prevention. And we're seeing other evidence-based programs for chronic disease or prevention to also be supported by a similar model. The accountable health communities that the Centers for Medicare and Medicaid Innovation Center tested is also had backbone organizations also acting as hubs, like the Denver Regional Council of Governments is one example that they were part of that model. They're also now a community care hub and trying to sort of further solidify their healthcare partnerships around Denver. So we've had, and Pathways Hub, I'll just call out, is another mature model. It's been around for decades now. Similar concept, really community health worker driven interventions and protocols, but really in partnership with healthcare. So there's lots of ways in which this model has evolved. as an agency, ACL has been supporting this work for over a decade across administrations. The Hartford Foundation and others have been key supporters of this work, as well as June was one of the earlier leaders in this space, having to support a broader community around this work. But I think now we are in this time in recent years, we've had a lot of collaboration across government, administration-wide on the federal side, but in particular in HHS, we've worked really closely with Medicare and Medicaid and CDC and our SAMHSA or our policy secretary's policy shop, really all together on not only a SDOH action plan, but their administration released a playbook for SDOH, which featured hubs as like a key component of that playbook. And then we had an HHS call to action because we recognize that there's so much screening in healthcare happening now, right? Hospitals and physicians and ACOs, all these different healthcare organizations are routinely screening for health-related social needs. So we anticipated there's going to be a lot more positive screens going to the community. We need to strengthen the community infrastructure to be able to do this work. And the more we can have an entity like a hub be able to not only being able to receive referrals, but be able to work across a network of community-based organizations that can address not only nutritional needs, but also housing and transportation and connection and home modifications, whatever is needed, that they have a network of providers they can be able to collaborate with very mature relationships and be able to ensure that referrals are acted on and as available payment for that from Medicare or Medicaid would also be then administered and distributed to the CBO. So the hub really plays that role of managing the network of community-based organizations and the service providers, but also in the contracting entity across multiple organizations. So they can take the funding from social services, from philanthropy, from the state, and also make sure that they can braid that with Medicare and Medicaid funding. So they're the administrative coordinators, but they're also sort of the managers of the network, and can, be able to support any key functions in the referral process, in service prevention or provision, but also being able to report on outcomes and say, okay, well, after these referrals for food insecurity, those that had diabetes not only had a closed loop, but they were able to get X, Y, and Z intervention, and they hadn't any possible, admissions. There's possibility for tracking closed loop referrals, but also we see down the road potentially related health improvements. So this is sort of the nuts and bolts of the conceptual model of being a hub, where they are able to sort of braid the different funding sources, but be able to sort of follow the whole process of screening, connection, service provision, referral, feedback, and tracking outcomes. And doing that for a broader population than what they might be able to reach alone through just their social service funding. So if we just had, for example, Older Americans Act funding or Rehab Act funding to be able to do all this work, we would only be able to serve a certain population. And many times we know people are on wait lists. So the concept is, if we have more of a community-wide and multi-payer approach to service delivery and organizing this across the community, then we're more likely going to be able to serve more people in need. And as referral volume is increasing, and in some cases we're hearing it's increasing by 70% in the last year, we really want to also help people have the systems to support the increased volume and the payment to increase that volume, and also the growing workforce. So you can hire more case managers, more community health workers, people that you need to be able to serve that broader population. So that in essence is sort of what we've been doing. I would just also note that, not only are we have the call to action out there to try to promote community partnerships and support community care hubs, not just ACL, but really all across HHS, trying to align our activities to support this work and policies. But we also intend to provide ongoing technical support, technical assistance, and through the Center of Excellence to Align Health and Social Care, we'll be able to provide some infrastructure funding to hubs that will be able to receive, or who have made it through a competitive process to receive some sub-grant funds.
Awesome. Thank you so much, Kelly. I think to your point, the innovation here is really in bringing the different social service providers together to bring that scale in terms of both for contracting with different funding sources, but also to improve capacity for the provider side to be able to address the diverse needs. But that's really a valuable insight. To your point, this has been happening over the years, but this is at the right time for this to be happening as well in terms of the demographic shifts and the learnings we've had from the pandemic and things like that. So thank you for sharing that conceptual model, because I do think there's a lot of people joining this call that are just learning about community care hubs. It's a really important market phenomenon in some ways for us to all learn about. And if you are a CBO, it's relevant for you to think about the different community care hubs that are being formed in your region. And then if you are a community care hub that's developing and building yours, then this can be a great way to learn from existing community care hubs in the system. So I'm really excited to now talk to June Simmons so she can share with us that Partners in Care has been one of the key pioneers in developing the community care hub model. Would love to hear your journey, June, and your learnings over the years on how I know you guys have learned, experimented, and improved your model over the years. So would love to learn about your experience.
Well, thank you. And always great to hear Kelly Cronin. ACL has been every step of the way in building this new model of care and taking it forth. And Kelly's leadership now is very important to address this, certainly for aging and disability, but of course the hub also then can extend and serve a wide array of populations. Well, the way we became a community care hub was we actually had a Medicaid waiver that kind of functioned like a hub. It was structured as a nursing home diversion arrangement. We still have it. And that was size limited and population focused. That seemed to us like really there was an urgent need for what we now see as an organized social care delivery system, rather than just one by one agencies trying to work with healthcare providers one by one, but to build a system of care that can be aggregated, that can be learned from, that can be co-designed. And so we have followed that path since at least a decade. We began with the John A. Hartford Foundation funding, which they agreed this was a worthy vision, and ACL was there from the start, working side by side to build this out and say, well, what would this be? How would it work? How would small organizations work with the big healthcare organizations? Who should be served? How should they be served? How would the services be paid for? So, and as Kelly noted, then the Community Care Transitions, a CCTP program came along, and that was an opportunity to take a common form of payment across agencies in a given geography. And that was one of our first efforts to try to organize. And then California had a duals demonstration in certain counties, and ours was one. And so that was an opportunity where the health plans actually had to contract with agencies. This is, if you think about it, a rather disruptive notion to take healthcare sector and the social care sector and try to get them to work together. They have very different regulation, very different payment, and healthcare was based on presenting problem episodes of care. Now we're shifting from reactive care when people show up to proactive care. So these are very fundamental paradigm shifts in how we look at human beings, population health needs, health disparities, and how do we address those. And so we did begin under these various opportunities, and it's sort of an opportunistic way, seizing moments where there was a meaningful partner, a meaningful population, and a way to build together some early prototypes of this kind of care. So an early one was Blue Shield of California, and they decided they would like to have a way to see what's happening in the home for people, what are drivers of healthcare other than the healthcare that they're getting, these powerful social factors people are up against. And they needed a statewide system, and they didn't want to have 200 contracts with small agencies to do that. So we built a very early statewide community care hub, whatever it was called at that time. It's what we call it now. So we've continued to seize opportunities, and now Elevance works across 23 states, and we're one. We lead a statewide set of local agencies that can be drawn on to serve their members, just like the Blue Shield members. If it's a health plan and they have a benefit, they have to serve members wherever they are in a consistent and uniform way. And so this allows a geographic reach through multiple local trusted providers. So this was a design that now is coming along, and multiple payers have stepped up. So we now work across populations and payer types. So Medicaid, it's a very big one.
Yeah.
California has CalAIM, a big shift in its design of how to address the very complex and socially and medically complex populations that drive the highest use and costs in the health system. About 5% of Americans use 50% of our health dollars. So this is a meaningful thing to look at and say, is it being done right? Could it be done better? And we see a lot of late access. Problems get big. We spend a lot of money on put people out on their own. So this community care hub is an effort to find people, engage people, which is one of the things you're working on, and really build an opportunity for them to decide if they're willing to have services that will assist them in reducing their poverty, increasing their knowledge and resources to manage health risks and health challenges more effectively. So frequent emergency users, the people in the hospital to prevent their readmissions, a wide range of other kinds of targeting opportunities that allow us to then try to transform the way we address population health, individual health, in real partnership with community agencies.
Thank you so much, June. That's very, very helpful. And to your point, in terms of the community organizations, they have a strength in terms of building the trusted relationships with the individuals in the community. And that's why there's a really good synergistic partnership here between healthcare and social care to engage that whole person. And given that, how did you go about building a scalable network? As you said, you're working with multiple payers, Medicaid, Medicare, which means you need a wide breadth of providers that you're partnering with. How did you achieve that scale over the years?
Right. Well, in the early days, this was a sort of a foreign notion. So we had to look for early adopters. And so we really searched for cultural fit, language fit, service expertise, and specifically geographic availability. And we looked for champions who were interested. We noted that at that time, Blue Shield had stepped up with his first model. And this was a transformative opportunity to change the whole delivery system. But it would be slogging through change in an early movement. And so we asked agencies to be willing to tolerate low volume, high demand, changes in the way they services. You have to respond quickly. You have documentation. You have all kind of demands when you're working with the health system, that they would do that as reformers, as policy changers, as organizations that really were motivated to build systems that would serve people better. So a noble purpose was our first bait, if you will. And I think that remains so, but now it's getting to be a thing. And we see now in most recent days, this year, that people are going, maybe I should be working with healthcare payers and providers, because I can find the people who need things, because they have the people, and I'll be able to serve people, fulfill my mission, and maybe increase my revenue base. So then many agencies step up on their own. I think then they learn the value of this, because it's quite demanding on both parts, healthcare payer and community, to build a contract. It takes a lot, takes time. And so many of them are saying, as they discover this notion, I think I'll do that on my own. Great. And we have the CCH as a backup if you'd like it. And we get quite a few adopters that are now coming. We had a surge recently because Kaiser, who's so respected, stepped into this and decided to utilize this hub model. And they announced that. And there are only 3 what they call network lead entities, of which we're one. Suddenly there's a sweep of interest because people go, wow, Kaiser's doing this, it must be good. Yeah, you can see the hub in the middle carrying that burden, if you will, and the learning opportunity to win the contract, run the contract, design the interventions, recruit and credential the agencies, train them, onboard them, provide all the IT necessary, monitor for compliance and quality, continuing training, billing. So basically running the business side so the other agencies can do what they do best, serve. So, so that has been kind of how we hope we've gotten them, with vision for transforming change, the opportunity to grow and serve, and then, of course, we really seek diversity in culture and language and fit, besides geographic match. And that's another piece of mission for people to join together around, that we can reach people we weren't reaching before. People with broken promises and shattered lives really need to be found, engaged, build trust in order to achieve change over time.
Thank you so much, June. I totally agree. I think that cultural sensitivity is really key to reach and engage the difficult to engage individuals. So making that into a large system and providing that scale is really, again, I want to underscore that importance here. So thank you so much for sharing that. And I also want to briefly introduce Paula Johnson. She's just joined us, the Bureau Chief of Harris County Area Agency for Aging. And as I mentioned earlier in the beginning, Paula has been running the Harris County Area Agency for Aging for the last, since 2017. But also in the last year or so, they've started developing a community care hub model in their agency. So I'm really glad Paula has joined us, so we can get this 2 extreme perspectives from June, who's been doing this since a long time, and then also Paula, who's started doing this in the relatively recent times. So Paula, would love to hear from you on what efforts your agency has started preparing to become a community care hub, and any early challenges or strategies that you've been building.
Sure. Thank you, Kavitha. So it's probably been about a year ago that maybe a little bit, maybe before that, I was able to participate. I was actually asked to participate on helping to design the, I think it's like not best practices, but the steps you should take or have when developing a community care hub. So I started with that work. And from there, my interest just sort of grew. I didn't know anything about community care hubs, and at first they were called network lead entities. And so, and we transitioned that somewhere in there, and I was able to go to DC and meet with the team and to understand a little bit better. And for us, it's just a natural fit. It's a natural fit for an area agency on aging. And I can say, especially for ours, we're the largest area agency on aging in the state of Texas. We provide many services because of our, of course, because of our funding, but we contract about 95% out. And so understanding the whole contract mechanism, it just felt comfortable. So we started our journey, and probably at least over a year ago, and we look for partners. And so the one special thing about our AAA is that we are embedded within the Houston Health Department. And so what greater partner to have than right there in your own front yard is the Houston Health Department. But we look for another partner, which is Ibn Sina Foundation, which they are operate like a primary care. Well, they are primary care, operate like a FQHC, but they're not. But they have been a great partner with us in the past. And then because we looked at another opportunity, UT School of Public Health reached out to us, and they were interested as well. And so we just sort of created our own network, and we have been working to develop a formal document between us, because we are local government and UT School of Public Health, the state government. You know, there's some challenges with that, but we're working through those. And then we also have a Houston Health Foundation. So we've been working between what's the best fit, and we had come to the agreement that being under the Ibn Sina Foundation works better. It gives us an opportunity. We don't just sort of cut through the red tape we would do with contracting. We have actually met with a lot of our contractors to talk about what a community care hub is and to gain interest, and we have. And so we're just now going through those next steps. Ibn Sina has a electronic health record. They do third-party billing. Health department also does third-party billing. We also have electronic health record. But what's the easiest way? So we're still sort of sorting through those opportunities, those things that we need to do so that we can fully be ready for that first contract. And so that's sort of what we've been up to.
Awesome. Thank you so much for sharing that. It's really refreshing to hear. I think especially the challenges in terms of being a government entity and working through this with multi-stakeholders is really interesting, and interesting to see how you are solving for it by working with different diverse stakeholders. So I know we're at 10 more minutes. So if we want to take any questions, I'm looking at the chat. I think one of the questions that came up early is like, who pays for this? Especially I want to take it from the community care hub model standpoint. As Kelly alluded to earlier, I think the goal of the community care hub model is to help diversify the funding sources to some extent towards social care. So I wanted to understand, Kelly, if you want to add anything on that, and then I would love to have actual examples that June and Paula can share as to who they are looking to contract with as well.
Yeah, I think in terms of who pays, well, it's, I guess the for what is part of the answer.
For the community care hub, yeah.
Yeah, right. So I think that the hub infrastructure are things that are developed over time and funded through different resources generally. I think June and Paula could perhaps talk about how the combination of funding they're finding to develop their workforce, their systems, you know, being able to have the ability to receive electronic referrals or to be able to administer, you know, manage revenue and administer billing. There's a lot of different functions involved with being that hub that you need to find funding sources to build up that capacity if you don't have it already. But then there's payment for the individuals, your workforce. So if you have community health workers or case managers or care managers, you also need to be able to pay for them. There's an increasing number of reimbursement opportunities under Medicare and Medicaid to cover that workforce, to be able to get them reimbursement for their time. For example, Medicare now pays for community health integration services under Medicare Part B, that explicitly calls out area agencies on aging and ADRCs and other community-based organizations that can be partners to a billing provider to be able to deliver those community health integration services and get paid for the coordination or the housing navigation or the care transition support. Many different things involved in that. There's a lot of opportunities for Medicaid to also get reimbursed depending on what your state's doing through their Medicaid authorities and program. So there's an increasing number of reimbursement opportunities depending on your healthcare partner and whether they're on the Medicare or Medicaid side, and also what's happening within your state on the Medicaid side. So that's in addition to what might be funded through the Older Americans Act, or through HUD if it's on the housing side, or other, things that you may be getting funded through. Like philanthropy has supported this work. Both local and national philanthropy sources have been nurturing this work for quite some time.
Absolutely. Thank you for that, Kelly. And so, June, if you want to add any specific examples on how you've been funding this.
Yeah, I think Kelly may have coined the phrase blending and braiding funding, because here we have community agencies that don't have big banks of capital, and you're trying to build a strong and reliable and sustainable business infrastructure. So, and you're doing so with a lot of partners who may or may not give a lot of volume. So we have, of course, enjoyed support from ACL providing support across the country, and we've been one of the recipients, the Hartford Foundation, and California's had startup funding, and a lot of our local foundations have also helped build this. But winning the contracts and then getting them to be more than a trickle, working through relationships with the healthcare payers and providers, whether it's the hospital, whether it's a medical group, whether it's a Medicaid health plan, whether now it's beginning to be Medicare, so that's a whole new startup, even commercial health insurance plans, to work with real live people to actually build sufficient scale that you can support this organizing business unit that needs to provide leadership and a platform for the operations to really then be able to properly identify the people in need, engage the people in need, which we've centralized because that's a whole function. We hadn't, usually community would receive referrals. Yeah. Now you receive referrals not by the person showing up, but by someone sending them. You get a list, 1,000 names, find and engage these people in services. They don't even know who you are. You're calling them cold. So building engagement, as you have done, and we have an engagement center that does that, working with these healthcare leaders at an interpersonal level to continue to put in place, design, and fully implement these new systems of care. That's an ongoing art form of mutual respect, discovery, and evolution of these systems of care. It's very, very important, I think, because we're all in a learning process. These are still new, even though now there are, let's say, 100, 150 community hubs across the country. Kelly named all kinds of different ones. It's still new as a field of practice, and building out this proactive articulation of who is in need, where if you bring social care, it'll change their health outcome, and therefore health dollars should come to address that. That is a whole design and implementation and evolution process. So I think relationship, broad engagement. We have all the Medicaid plans in our Southern California region. We have statewide commercial plans. We have hospitals. We're starting to get doctor practices. Engaging each of those and customizing and building out, that's a leadership function that's really crucial. And then demonstrating the results. As Kelly said, who pays for what? Well, it depends on who saves money if they do that, who gets better quality scores, who has other benefits. So I think building this out so that it's at a practical level, really a major success for the people served and the people trying to serve them together. That is really the great adventure that we're on now.
Yeah, absolutely. I think the start of that is the infrastructure that you guys are building, and that's why it's amazing. Without that scale, it's difficult to prove that model is working. So I'm really excited about that. I know there were some questions, and I'm glad Christine is helping with this, around how does somebody get started? If there is a group of organizations in a community, like they mentioned here, from a rural community, there's a home and community-based organization that Renee is from, and they're looking to start a community care hub. Where do they start? How do they learn? I know, Paula, you shared some resources. I would love all of you to answer this question. June, if you want to start, it's fine.
Well, we will share some resources on the Partnership to Align Social Care. That is an exciting national collaborative. It's what we call cross-sector. So it means hospitals, health plans, medical groups, CBOs, change agents, associations, voice of the consumer, government are working together on how do you build a hub. And there are a lot of materials on their website, which I know you're going to publish here, and how to have a contract and so on. But I would say the first place is, it's great those agencies are talking to each other. What's the population they want to help? Who has them and could use help with them? And how do you go and build an actual relationship with those people? So it's kind of new for us to be going out and say, I think I'm going to talk to the CEO at the local health plan. Or I'm going to talk to the hospital at the top level and do something beyond just referring meals. I want to really build a partnership around a new service arrangement with a business arrangement embedded to support it. So I think getting this kind of comfort with this kind of leadership, this kind of outreach, and this assumption that even though we're small, we're a rounding error to most of them, that this is an egalitarian co-design, and that the community is really the missing specialty in healthcare that they need to have, helping them understand that without insult, helping them engage in that, and then really look at, okay, let's build it. Let's build it together with consumer voice, with all these various impacted voices so it works for everybody. Otherwise, if it's not a win-win, it's not going to hold up. So I'd say it's a collaborative venture with confidence and joy in engaging new people and helping them understand it's a big opportunity.
Absolutely. Thank you so much, June, for sharing that. I know we're at the end of the time, so I want to give Kelly and Paula a final point. Anything you want to share about resources or any upcoming changes you see in the community care hub world? Paula, you want to go?
Sure. I'm seeing the interest. When I talk to other agencies or other organizations about what we're doing, I go back to where at some of the national conferences, probably maybe six, 7 years ago now, when the conversation was how health systems and managed care organizations should work with community-based organizations with AAAs so that the patient or the clients have better outcomes. And so now to start seeing things so slowly revolving and to be a part of that, there's still, I'm so appreciative of June and partners, I may get it right, Partnerships to Align Social Care, for what they've done, because in ACL with the new language, new verbiage, the updates of the Older Americans Act, all of that coming together, the different collaborations, the different learning groups. I'm trying to just join all of them as much as I can, because it took me a while to even understand blending and braiding. Now I got the term. So I was just telling someone recently, excellent. We need to talk about blended and braided. And so then I was able to understand it, but understanding all of those new concepts. And then the last thing I probably would say, because I'm probably mumbling, is to find someone that has a hub or a community care hub. And I'm looking at Nikki Kaminsky right now. I met her sometime last year, but she has been a great help. Alabama has a great community care hub. We've been in touch with them, and they've shared documents with us to help us get started. So reaching out to others that are trying to do this work, or actually doing the work, successful at doing the work, is a great way to start. Also, just to have something or someone to bounce things off of. So thank you for that.
Thank you. Kelly?
I think you've heard so many good things from Paula and June. I'll just add that I think that this kind of work is here to stay for a long time because it's needed, right? We need to have more full support for the populations we serve, and it needs to be a more seamless experience for them, and they need to be better supported at home in their communities. So I think we're going to be providing as much support as we can moving forward. And I think the more we stay connected across levels of government, the better the easier it should be, hopefully, for leaders at the community level to make this work happen. And we're going to also try to, continue to work on the policy side to make sure that the reimbursement opportunities can also support this work. So stay tuned, get involved. You don't have to be a hub. You can be part of a network, as June and Paul have said, but just try to get engaged, because this is an area we think is going to lead to greater impact and is in complete alignment with mission.
We're touching lives for the better,
Yeah.
ways we couldn't before. So that's really the ultimate purpose and dream.
Absolutely. Thank you so much for all your leadership and the advocacy you're doing. And this is really, as you said, a key paradigm shift that's happening. I'm really glad you all took the time to come here and share your thoughts. I know 45 minutes wasn't sufficient. There's still a lot more to talk about, but this has been really a good start. Thank you so much for all the information and resources you shared. A final shout out to everybody to join us at the Blooming Day event on June 21st in New York City, or online as well. We can continue the conversations there. Have a wonderful
Your
evening.
leadership.
Yeah, thank you.
Yeah.
Have a wonderful day. Bye-bye.
Bye-bye.